Hello, and thank you for joining us for the 6th Annual Global Summit on Kidney Disease Innovations, Vox Populi. The time is now to prevent and cure kidney diseases. This summit is hosted by the American Association of Kidney Patients in partnership with our allies from the George Washington University School of Medicine and Health Sciences. My name is Carl Juresic, and I'm a kidney transplant patient and an AAKP International Ambassador from Australia. I've had chronic kidney disease for over 23 years. As a teenager, I was diagnosed with ANCA vasculitis, and unfortunately, it affected my kidneys. 10 years later, I needed a kidney transplant, which my dad generously donated. And 13 years later, lucky enough, I still have that transplant today. In my professional life, I've always worked in strategy and consulting. For the last 15 years, I've worked at companies such as PricewaterhouseCoopers, Accenture, Facebook, and I'm currently leading Uber ads across the APAC region from a strategy and insight perspective. I'm also the founder of Kidney Ally, a health tech company dedicated to empowering patients to slow down the progression of kidney disease. AAKP is incredibly important to me. It connects me with a community that is so integral to my everyday life. And since joining as an ambassador 4 years ago, I've had so many opportunities to empower patients on their journey, and I love how the community fosters this connection. This year's Global Summit theme, Vox Populi, was purposely and strategically chosen by the AAKP for its historical meaning, voice of the people. I am one of the people they have chosen to raise their voice in support of greater care decisions and innovation around kidney care. And I am one of the voices demanding change in the status quo of kidney medicine. Over 850 million individuals in the world have some form of kidney disease, and this number is increasing every year by 5 to 7%. And every year we lose thousands of innocent lives to preventable kidney issues due to the lack of timely access to treatment. AAKP believes kidney disease is both a workforce and a healthcare issue. The disease takes a devastating toll on human life and livelihoods. Most people understand that kidney disease left undetected and untreated can lead to premature death. However, most are unaware of the way it impacts a person's dignity and the ability to provide for themselves and their families. Kidney diseases and outdated treatments can lead to unemployment, underemployment, disability, and dependency. In 2019, AAKP declared the next 10 years as the decade of the kidney. The time is now for kidney patients, consumers, healthcare professionals, researchers, industry, and all people of goodwill to unite our voices and demand change. We are optimistic we can save more lives. But to do this, we must demand new screening guidelines, diagnostics, new biologics, and new devices. Together, we can manage and solve this growing public health crisis. The time is now for elected and appointed leaders worldwide to listen to patient voices. Governments must remove the regulatory and payment barriers they create that delay innovation and prevent timely access to care. If governments fail to do this, we must raise our voices and demand an end to negative government determinants of health. Make no mistake, every nation is impacted by kidney disease and millions of people are at risk. The optimistic news is that every person watching this today can help those impacted by kidney disease and make an impact within their own nation. Through AAKP Global, AAKP is educating patients, care partners, healthcare professionals, and policy leaders across the world on unmet patient needs. Our annual Global Summit on Kidney Disease Innovations has helped put a human face on what is now the 10th leading cause of death based on data from the World Health Organization. We have connected people across the globe in common purpose larger than any one person or nation. Together, we have increased hope and optimism. So thank you for joining us. Your voice is the voice of the people, and you can count on AAKP to keep amplifying it throughout the world to create change. With that, I am honored to serve as the moderator for our session entitled Identifying a Core Cancer Outcome for Kidney Transplant Trials. Our first speaker is Dr. Ellen Dobrijevic, a physician trainee from my hometown, working in New South Wales, Australia, and a PhD candidate in the Faculty of Health and Medicine at Sydney University. She researches the intersection of chronic kidney disease, cancer, and socioeconomic status. Dr. Dobrijevic is also the project coordinator for the Standardized Outcomes in Nephrology, commonly known as SONG initiative, which aims to establish a core set of outcomes and outcome measures across the spectrum of kidney disease for trials and other forms of research. The outcomes will be developed based on the shared priorities of patients, caregivers, clinicians, researchers, policymakers, and relevant stakeholders. We are delighted to have Dr. Dobrijevic with us to share more on this initiative. Please take it away.
Hello, thank you to the AAKP and GW University for inviting me to present at this great conference. My name is Ellen Dobrijevic. I'm a physician trainee at in Sydney, Australia, and a PhD candidate at Sydney University. Today I will be presenting some of my work in the Standardized Outcome in Nephrology, or SONG initiative, in particular the work of the Transplant group in cancer. The SONG initiative is a research group that aims to establish core outcome sets across the spectrum of kidney disease. We have 7 streams for hemodialysis, peritoneal dialysis, children and adolescents, polycystic kidney disease, glomerular disease, and transplantation, which is the focus of my talk today. We aim to identify outcomes that are developed by and reflect the shared priorities of patients, caregivers, and health professionals, including clinicians, researchers, policymakers, and industry leaders. The SONG initiative has involved over 10,000 people, with more than 1,000 people in each stream from over 70 countries. Throughout all stages, we involve patients, caregivers, and a wide variety of health professionals. Before going on, I would like to acknowledge the Transplant Cancer Working Group listed here, and in particular, my research supervisor and the working group chair, Professor Jermaine Wong, and Professor Alison Jare, who is an executive committee member of SONG, one of the key drivers of the SONG initiative, and who supplied some of the slides for my talk today. Before I get into it, I will provide some definitions. An outcome is something that can arise or change because of a health condition or treatment. For example, graft function. An outcome measure is the specific instrument, measurement, or metric used to capture and report the outcome. These are reported in clinical trials and other research, and it could be graft function, captured by creatinine level. Core outcomes are ones that have been identified as critical to report in trials in a particular area. A core outcome set is developed and encouraged to be reported in all trials in an area as a minimum. Trials can then add additional outcomes to the core set as indicated by their study. Currently, there are a wide array of outcomes and outcome measures that are reported in kidney transplant trials. The SONG transplant team looked at all systematic reviews and trials involving kidney transplantation up to 2015 and looked at the outcomes included and the outcome measures. They analysed 397 trials that included over 63,000 participants. There were over 12,000 outcome measures reported. The 4 most common outcomes were graft function, with 118 different outcome measures, acute graft rejection, with 93 outcome measures, graft loss, with 48 outcome measures, and mortality, with 51 outcome measures. However, only a third of the trials in immunosuppressive therapy in kidney transplantation reported all 3 critical outcomes of mortality, graft loss, and kidney function. Only 50% reported cancer or infection, and only 15% of the outcomes were patient-reported outcomes, which are outcomes that are directly reported by patients without interpretation and include things like quality of life, functional status, or symptoms such as pain and fatigue. So, why do we need core outcomes? Identifying core outcomes helps us make research relevant by encouraging trials to report issues that are important to patients, caregivers, and health professionals. Core outcomes also help improve certainty by helping standardize the outcomes reported by research and improving the comparability between trials. Core outcomes therefore help make research more efficient by answering the questions important, relevant, and can help inform decisions. There is a great need to develop a core outcome set for kidney transplantation, As shown in the previous slide, there is inconsistent reporting of key outcomes and a wide variety of outcome measures, which limits comparability. By identifying core outcomes and promoting their use in trials, we are working towards making research more meaningful, relevant, and comparable. One of the key principles of the SONG initiative is that it involves patients and caregivers at all stages of the process. Patients and caregivers are involved as part of the steering committee and expert working groups, as co-investigators and authors on publications, and as project leads. Patients and caregivers are critical participants in our surveys and workshops, which form part of the consensus process. Patients and caregivers also form key parts of our network, helping us expand, develop collaborations, and advocate for implementation and share our work. It is critical to include patients and caregivers at all stages of the SONG process because of their insightful perspectives, lived experience, passion, and skills. Often reported outcomes in trials are biomarkers or clinical endpoints, some of which are not relevant or considered as important by patients and caregivers and do not affect decision-making. The effective interventions in terms of functional, social, and emotional well-being are often not assessed. The graph here shows that a set of proposed outcomes posed to health professionals and patients and caregivers by the SONG team. The outcomes with points on the right were favoured as more important by patients and caregivers, while those on the left were favoured as more important by health professionals. You can see here that there are discrepancies in the rankings of some of these outcomes. For example, patients and caregivers considered outcomes that reflected their quality of life or functional status, like cognition, depression, and ability to work, is very important, while health professionals often focused on clinical outcomes, like graft loss and hospitalization. Bringing everyone together to ensure that the core outcome sets capture what is important to patients, caregivers, and health professionals is required to make research more relevant and impactful. This slide is an overview of the SONG process. The SONG initiative follows a validated methodology developed by the Outcome Measures in Rheumatology, or UMERAC, and COMMET initiatives to develop core outcomes. To identify a core outcome domain, first, a systematic review of the existing literature is conducted to assess what outcomes and measures are being reported. Next, focus groups are conducted using nominal group technique with patients and caregivers to identify and rank outcomes. Further interviews are conducted to develop the outcome domains that are presented in the Delphi survey. The Delphi method aims to achieve consensus through a series of surveys. I will walk through the Delphi surveys for the transplant group soon. The results of the Delphi survey are taken to a consensus workshop, which is held in person or online with patients, caregivers, and health professionals. At the end of this process, the core outcome domains for a particular area are confirmed. For each outcome domain, we then have to determine the outcome measure to capture it. Similarly, this process starts with a systematic review of the literature to determine how that outcome domain is currently being reported. With the input of an expert working group, those results are translated into a survey that is distributed to patients, caregivers, and health professionals. The survey results are presented at a consensus workshop where the core outcome measure is hopefully identified and confirmed. That core outcome measure then requires piloting and validation for use. The Delphi surveys are conducted over 3 rounds. The initial outcomes are identified from the stages mentioned before. They are reviewed by the executive and piloted to a small group of patients and caregivers. Round 1 from the transplant string was conducted by 1,018 participants. 45% of them were patients and caregivers from 79 different countries. Each person rated the importance of the outcomes on a 9-point Likert scale and had space for comments. Outcomes that had a mean and median rank of greater than 7 were taken to the next round, and new outcomes suggested by more than 10% of respondents were added to the next round. In rounds 2 and 3, the participants re-rated the outcomes after reviewing their own scores and the distribution of the other responders' scores in the previous rounds and the comments. In round 3, respondents also conducted a ranking exercise where they had to order all the outcomes from most to least important. Round 3 was completed by 779 people. Consensus for an outcome domain was based on both groups, being patients and caregivers and health professionals, having a median score of greater than or equal to 8, a mean score of greater than or equal to 7.5, and the proportion of participants ranking the outcome as critically important being greater than 75%. At the end of round 3, 8 outcomes met the consensus criteria, and these were graft function, mortality, acute rejection, chronic graft rejection, graft loss, infection, cardiovascular disease, and cancer. These outcomes were consolidated into the core outcome set for kidney transplantation that includes graft health, cardiovascular disease, cancer, infection, life participation, and mortality. Middle and outer tier outcomes were also included and shown in this diagram, such as the ability to work, anemia, bone disease, cognition, fatigue, and hospitalization. Now moving on to the core outcome measure for cancer. To recap, these are the broad steps we follow to identify a core outcome measure. First, a review of previous literature is conducted to identify how cancer is currently being reported. Next, a specifically formed working group, shown before on one of my first slides, takes the results of the review and develops a survey with the proposed cancer outcome measures that's completed online internationally by patients, caregivers, and health professionals. The results of the survey are then analysed, and the key points are presented in a consensus workshop to attempt to come to an agreement of what the core outcome measure for cancer should be. Cancer is a scary diagnosis. It is particularly important in kidney transplant recipients because they are 4 times more likely to develop cancer and 2 times more likely to die from cancer than age and sex-matched peers. This increased risk is thought to be due to the effects of long-term immune suppression, cancer-associated viruses, and an inflammatory state. Despite being at an increased risk of cancer, kidney transplant recipients are less likely to be included in trials for cancer therapies, and cancer is reported in trials. This contributes to uncertainties in decision-making around the screening and treatment for cancer in kidney transplant recipients. The Phase 1 systematic review looked at 819 trials in kidney transplantation from 2000 to 2021. Only 10% of trials reported cancer as an outcome. When cancer was reported as an outcome, it was the primary outcome, or the focus of the study, in 14%, or 12 studies, and reported as a secondary outcome in 86% of trials. There were 72 different cancer outcome measures, or ways of reporting cancer, taken at 20 different time points. More than half of the trials only reported cancer at a single time point. 55% did not mention a specific cancer type. Furthermore, only one trial reported cancer-related death. We ran a survey from March to December in 2023 to determine what cancer outcome measure was the most important to patients, caregivers, and health professionals. 7 proposed outcomes were presented. The survey was completed online by 403 people in English and Spanish. 57% of the respondents were patients, caregivers, or kidney donors. 55% of the respondents were women, and they came from 55 different countries, the most common of which were Australia, the UK, the USA, Canada, and Chile. Phase 3 for the cancer outcome was the consensus workshop. The results of the survey were taken to the workshop, which was held on Zoom in late May. There were 69 participants from 11 countries. 21 were patients and caregivers, and 48 were health professionals. During the workshop, we had great discussions of the proposed outcome measure for cancer. There was a focus on what information patients and caregivers would want in relation to a cancer diagnosis, the impact on them emotionally, on their quality of life, and the burden of potential treatments. These discussions are always enlightening, as patients and health professionals inform each other of aspects and perspectives that are new to one another. There was an acknowledgement of the serious concern cancer leads to in transplant recipients. One patient said, "While my kidney graft might last, other things like cancer might get me." In developing an outcome measure, there needs to be a balance between capturing a lot of detail that is important and developing a concise measure. There was general consensus that the outcome measure needs to be quite broad. One patient said, "It's about capturing all the different types of cancer that affects our community. And we had some really interesting discussions around balancing all the information patients would want to know or receive about cancer, and clinician concerns about making the outcome measure simple enough that people will adopt it, and broad enough that it can apply to all trials. In summary, the SONG initiative has 7 streams for which it is developing core outcome sets that span the spectrum of kidney disease. Core outcome sets are important to ensure that research is relevant, comparable, and can be used to support shared decision-making. The SONG initiative forms a rigorous and inclusive framework developed by Umaract and Comet. Our initiative includes people from diverse backgrounds, includes patients, caregivers, and health professionals at all stages and from across the world. The SONG Transplant Cancer Outcome Measure is currently under development and should be finalized and published soon. It will then enter piloting and validation stages. If you want to learn more about the SONG network, you can visit our website. Further, if you're interested in being involved in our work through joining a group, participating in one of our surveys or workshops, you can register to join our mailing list either through the link on the screen or through the QR code. Thank you again to the AAKP and to GW University for inviting me to share the SONG initiative's work here.
Thank you, Dr. Dobrijevic, for that excellent presentation. Before we move on, though, I'd like to ask you a few questions. Based on your research and experience, how critical is it for transplant patients, organ donors, and their families to raise their voices? Alongside medical professionals, in the push to address cancer issues among transplant recipients. We think patients across the world can gain encouragement by our observations.
Thank you for the great question. I think it's critical that patients, caregivers, organ donors, organ recipients, all have a voice in advocating for what is most important to them in terms of cancer and in terms of their health in general. Without working together with patients and caregivers, as I was talking about earlier, often research doesn't quite reflect what's most important to them on a day-to-day basis and will make a difference in their lives. And so coming together with patients and caregivers, with health professionals, really lets everyone get onto the same page about these are the things that are important, these are the things we need to research in to get more information to really make a difference.
And based on that research you've reviewed, if you were a transplant patient today with a transplant, say, of 5, 10, 15, 20 years, are you more or less optimistic of where science is heading in terms of solutions than you were, say, a decade ago?
That's a very challenging question. I think generally, yes. Medicine is continually making steps forward in terms of improving outcomes, improving quality of life for patients over a wide variety of conditions. I think particularly in cancer and kidney transplant recipients, there's still a lot of work that needs to be done in figuring out how to screen for the cancer, the best way to go about treating the cancer, and that more evidence needs to be developed to support these decisions, as a lot of it currently is based off clinical practice and not great trials or solid evidence.
So, Doctor, as you may know, in the US, kidney transplant patients, organ donors and professionals are really working hard to push the US FDA to adopt new clinical endpoint for transplant drugs. The current endpoint is around 1 year graft survival and is over 20 years old and does not encourage any innovation. What encouragement would you give to patients like myself to keep raising their voice to encourage greater innovation on new transplant drugs?
Once again, a really great and thoughtful question. I agree that we often get stuck in our ways in terms of what endpoints and what outcomes we report in trials, or what are reported in trials. And the only way we can work towards changing that is through advocating for what, as a group of health professionals, patients and caregivers, think is most important. In terms of encouragement, I would say get involved in the AAKP, as I'm sure everyone listening to this is, get involved in other networks and initiatives like SONG, and forming groups that can advocate as a body and make more of a difference in individual voices is a great way of going about that. And then on an individual level, there's even space for bringing up these conversations with health providers, if involved in trials, to talk to the trial people you're involved with to make sure you get the results of the trial and that they're taking on board your questions and concerns.
Thanks, Doctor, for those inspiring responses. We are ever grateful for the opportunity to learn from such a knowledgeable and engaging speaker about the Song Initiative.